Blood and urine are the most common diagnostic fluids in veterinary medicine, but they're not the only ones. Today we're going to talk about two other fluid compartments that carry enormously useful diagnostic information: cerebrospinal fluid from the nervous system and effusions from body cavities, like the chest and abdomen. In each case, we're going to apply the same systems-based approach. What is this fluid normally? What happens when the system is disrupted? And what are the cells and chemistry telling us? Spinal fluid is the nervous system's private ocean. It bathes the brain and spinal cord continuously, acting as a mechanical cushion, delivering nutrients and clearing waste. Under normal conditions, CSF is crystal clear and nearly cell-free. It has very little protein because the blood-brain barrier tightly controls what can enter this privileged space. When the nervous system is inflamed by infection, immune-mediated disease, or neoplasia, the blood-brain barrier breaks down. Cells and protein cross into the CSF, and that's exactly what we're looking for when we tap it. CSF analysis is indicated when a patient has neurological signs and imaging alone hasn't given you a definitive answer. It's not a first-line test, but in the right case, it's irreplaceable. CSF collection requires general anesthesia. The animal must be absolutely still because the needle is near the spinal cord. The cerebellomedullary cistern, the space at the back of the skull, is the most commonly used site and is ideal for brain disease. Lumbar taps are better for investigating spinal cord lesions. One of the most important practical points: process the sample immediately. CSF has very few cells normally, and those cells start to degrade within 30 to 60 minutes of collection. A 1-hour delay can mean the difference between finding cells and finding a ghost of what was there. And always note the color. Normal CSF is as clear as water. A yellow tinge, called xanthochromia, indicates there has been previous hemorrhage into the CSF because hemoglobin breaks down to bilirubin over days. Fresh blood in the CSF that clears with continued flow suggests a traumatic tap rather than true CNS hemorrhage. Four numbers define a CSF result: the total cell count, the differential, the protein, and any special cytological findings. The total cell count tells you whether there's pleocytosis, too many cells, and how significant it is. The differential tells you what type of immune response is happening. Neutrophilic pleocytosis is the hallmark of bacterial meningitis, but also of steroid-responsive meningitis, arteritis in dogs, a common immune-mediated condition in young, large breed dogs that presents with severe neck pain and fever. Lymphocytic or mononuclear pleocytosis points toward viral disease, immune-mediated encephalitis, or neoplasia. Eosinophils in CSF are unusual and make you think of parasitic migration or certain fungal infections. And always look carefully at the cells themselves. Occasionally, you'll see organisms like Cryptococcus with its distinctive capsule, or find neoplastic cells from a CNS tumor. Here are the most clinically important CSF patterns you'll encounter in practice. SRMA, steroid-responsive meningitis, arteritis, is one of the most satisfying diagnoses because these dogs respond dramatically to prednisone. They present with severe neck pain, a high fever, and a CSF that's loaded with neutrophils, but completely sterile. No organisms anywhere. GME, granulomatous meningoencephalitis, is an immune-mediated condition of the brain parenchyma, more common in small breeds like pugs and Maltese, and it gives a more mixed CSF picture. Cryptococcus is critical to recognize because it's treatable. Those big encapsulated yeast organisms are often visible on cytology, and the serum cryptococcal antigen titer is an excellent sensitive diagnostic test, and CNS lymphoma can present with large atypical lymphocytes in the CSF. Always look carefully at cell morphology. Before we classify effusions, let's understand why fluid accumulates where it shouldn't. There are four main mechanisms, and they're worth understanding because the mechanism predicts the type of effusion. Increased hydrostatic pressure from right heart failure pushes fluid out of vessels into body cavities, the classic cause of a modified transudate. Low oncotic pressure from hypoalbuminemia, when there isn't enough albumin to hold fluid in the vessels, causes a similar picture. Increased vascular permeability from inflammation, infection, or neoplasia allows cells and proteins to leak into the cavity, creating an exudate. And lymphatic obstruction, as in chylothorax, causes accumulation of lymphatic fluid that can't drain. Each mechanism produces a characteristic fluid composition, and that's how we classify effusions. Effusions are classified based on two primary measurements: total protein and nucleated cell count. A pure transudate has almost no cells and very little protein. The fluid leaked out passively because oncotic pressure was too low to hold it in. A modified transudate has more protein and more cells. This is what you see with right heart failure or early neoplastic effusions, where increased hydrostatic pressure or mild vascular disruption is driving the leak. And an exudate has high protein and high cell counts because there's active inflammation, infection, or neoplasia causing significant disruption of the vascular barrier. The classification immediately narrows your differential list. A pure transudate in a hypoalbuminemic patient with ascites points you to the liver or kidneys. A septic exudate points you to an emergency surgical abdomen. The most important distinction you will ever make in effusion analysis is septic versus non-septic. A septic exudate means there are bacteria in the body cavity, and that almost universally requires emergency surgery. The microscopic findings are dramatic. Degenerative neutrophils whose nuclei have been destroyed by bacterial toxins, with bacteria visible inside and outside the cells. Don't wait for culture results if you see intracellular bacteria on the slide. The effusion glucose test is a rapid bedside tool. Measure blood glucose and effusion glucose side by side. If the effusion glucose is more than 20 milligrams per deciliter lower than the blood glucose, or below 50 milligrams per deciliter absolute, bacteria are consuming that glucose and sepsis is likely. This test takes 2 minutes and can confirm your decision to go to surgery. 3 special effusion types deserve their own mention because they have specific diagnostic tests that are simple, fast, and definitive. Chylous effusion, chylothorax, produces a striking milky white fluid from lymphatic triglycerides. Comparing effusion triglycerides to serum triglycerides is diagnostic. Effusion triglycerides significantly higher than serum confirms chyle. Bile peritonitis from a ruptured gallbladder gives a yellow-green or bilirubin stained fluid, and comparing effusion bilirubin to serum bilirubin is the test. And uroabdomen, urine leaking into the abdomen from a ruptured bladder, is confirmed by comparing effusion creatinine to serum creatinine. Because the bladder ruptures and urine equilibrates with body fluids, serum creatinine rises, but effusion creatinine, directly exposed to leaked urine, will be significantly higher. Any of these 3 comparisons can be done with the same chemistry analyzer you already have in your clinic. Let's bring it home. CSF and effusion analysis are both fluid stories, and both follow the same logic. Normal fluid is minimal, clear, and nearly cell-free. When disease disrupts the system, cells and protein enter, and the type of cells tells you the type of disease process. For CSF, pleocytosis type points you toward the cause. Neutrophilic for bacteria and SRMA, lymphocytic for viral and immune-mediated, eosinophilic for parasites and fungi. For effusions, classify first, transudate, modified transudate, or exudate, and then look at the cells. And never ever delay acting on a septic exudate. Intracellular bacteria on a cytology slide is a surgical emergency. The fluid is telling you a story. Your job is to read it. Question 1. Young dog, severe neck pain, fever, stiff neck. CSF is packed with neutrophils, but no bacteria, no degenerate cells. Culture is pending. What's the most likely diagnosis? And notice, this is a young dog with a dramatically elevated cell count, but sterile fluid. What should you be thinking? This is SRMA, steroid responsive meningitis arteritis, and it's one of the most common neurological presentations in young large breed dogs in practice. The CSF is telling you everything. A massive neutrophilic pleocytosis with no organisms and non-degenerate neutrophils. The neutrophils look healthy. They're not being poisoned by bacterial toxins, which tells you this is not bacterial meningitis. SRMA is an immune-mediated vasculitis of the meningeal arteries. The body is attacking its own blood vessels in the meninges. Treatment is immunosuppressive doses of prednisone, not just a pain-reducing anti-inflammatory dose. The response is often dramatic. These dogs improve within days, but the tapering needs to be slow and monitored, often with repeat CSF analysis, because relapsing too quickly causes relapse. With proper management, the prognosis is excellent. Question 2. Milky white fluid from the chest of a cat. Effusion triglycerides are 10 times higher than the serum. What's the classification? What are you thinking for differentials in a 5-year-old cat? And what needs to happen next? Chylothorax confirmed. Effusion triglycerides nearly 11 times higher than serum is clear-cut. The milky appearance is from triglyceride-rich lymphatic fluid that should be traveling through the thoracic duct, but is instead leaking into the pleural space. In a 5-year-old cat, your top concerns are lymphoma, the most common cause of chylothorax in cats, and hypertrophic cardiomyopathy, which is the most common cardiac disease in cats and elevates lymphatic pressure by backing up venous return. Before anything else, drain the fluid and give oxygen. A cat in respiratory distress cannot wait for diagnostics. Once stabilized, echocardiography is your highest yield next step. It rules in or out cardiac disease quickly. If the heart looks normal, look for a mediastinal mass on thoracic ultrasound. A cranial mediastinal mass in a cat is lymphoma until proven otherwise. Question 3. Trauma patient, no urine output in 12 hours, free abdominal fluid. Effusion creatinine is almost 3 times the serum creatinine. What does that tell you? What additional test confirms the diagnosis, and what needs to happen next? Uroabdomen from a ruptured bladder is confirmed by this effusion-to-serum creatinine ratio. Here's the physiology. After the bladder ruptures, urine pools in the abdomen. Creatinine is a small molecule that gets reabsorbed across the peritoneal membrane into the bloodstream, so serum creatinine rises significantly. But the effusion itself is directly bathed in urine, so its creatinine is much higher than serum. A ratio greater than 2:1 is diagnostic. The same logic applies to potassium. Urine is rich in potassium, which gets absorbed into the bloodstream, potentially causing dangerous hyperkalemia. Check an ECG on this cat immediately. The treatment plan has a clear sequence. Stabilize the cardiovascular and electrolyte status, confirm the rupture site with contrast cystography or CT, decompress the bladder if possible with a catheter, and then proceed to surgical repair. Don't rush to surgery before the cat is stable. Hyperkalemia kills before the surgeon can help.